Good morning and welcome to Primary Children's Pediatric Grand Rounds. I am Miguel Canaco, Pediatric Hospitalist and Course Director, and today our topic is anxiety in children. Thank you all so much for joining us this morning. You can ask your questions of Dr. Strawn from Cincinnati Children's anytime during the presentation in the live chat, and I will ask for you when it's question time. And we will leave this video up all day. To claim credit within 24 hours on Cloud CME, you use the code 7958. That's 7958. And please claim this credit whether you need it or not. And now, Dr. Lisa Giles of Child Psychiatry will give a safety story and introduce our speaker.
All right. Well, thank you, Miguel. Again, pleasure to be here and super excited for our speaker today. So in terms of a safety story, wanted to share an experience we had on our inpatient psychiatric unit a couple weeks ago. There was a 14-year-old male with a history of depression and anxiety who was admitted to our unit secondary to persistent suicidal thoughts and just having all that ongoing suicidal ideation and suicidal thoughts. He had presented to our emergency room the day before, and as is way too common these days, unfortunately, there were no psychiatric beds available for him. So he boarded on our medical floor for over a day until a bed opened up. And then he came out to our unit early one Saturday morning. And one of our particular nurses did a fantastic job in his admission. And notice when she was doing admission vitals on him that his blood pressure was lower than she thought it should be. Looked around 80s over 40s, and interesting because his blood pressures up at the hospital had been recorded as 110s, 120s over 70s to 80s. And she did a fantastic job of, repeating that several times. Obviously, 99% of the kids on our inpatient psych unit have normal vitals. And so when things start seeming a little off, this nurse did a fantastic job of recognizing that and repeating that. And she talked to our psychiatrist that was on the unit about this, what was going on. So, asked a question. And was able to do, and they repeated some manuals and continued to monitor it for a couple hours, and that blood pressure continued to drop. And so they very appropriately then reached out to the hospitalist team at our main hospital here at Primary Children's to ask some questions and clarify. And turns out that this kid, rather than just being continued on his home medications while he was here at the hospital, had been given extended release guanfacine 3 times a day, as opposed to immediate release guanfacine, and was now, the next day after, having this cumulative effect of some low blood pressures. So just a great example, I think, of our nurse really using that ARCS and asking a question and requesting a change and making sure that we continue to not just let it, push under the wayside, that I think would have been easy for her to do. And so now I want to go ahead and introduce our speaker, who I'm super excited to introduce, Dr. Jeff Strawn. He's an associate professor of psychiatry, pediatrics, and clinical pharmacology at the University of Cincinnati. He's director of the UC Anxiety Disorders Research Program and the associate vice chair of research in the Department of Psychiatry and Behavioral Neurosciences at the University of Cincinnati. His research really focuses on anxiety disorders and the risk factors for those conditions, as well as the pharmacologic treatment of anxiety. And his research has been funded from the National Institute of Mental Health and the Patient-Centered Outcomes Research Institute, among many others. He really, Jeff, I had the fortunate to first meet Jeff as a resident back just, a few years ago. And Jeff really is just a wonderful ambassador for child psychiatry. He's exceptionally skilled in psychotherapy as well as psychopharmacology, and an excellent researcher and a teacher. And he truly is one of the world's leading experts in childhood anxiety disorders. I was given a story from one of our colleagues that I'm going to share about him that I think is really impressive, that in medical school, at the beginning of gross anatomy, he was the only person in that group of 4 that was interested in psychiatry. But the time, 4 years later, all 4 of them were residents in psychiatry, including our own Brooks Keeshan. And again, he's always been that ambassador for psychiatry. Jeff and his family love to ride their horses in their home in northern Kentucky. And of course, as a lifelong Kentuckian, I am told he's pretty familiar with the latest and greatest single barrel bourbons. So you can ask him those questions later as well. But with that, I will turn it over to Dr. Jeff Strawn.
Thank you so much, Dr. Giles. It's really a pleasure to be here, albeit virtually, and I look forward to a nice discussion about any of the things that Dr. Giles mentioned. So the talk this morning is actually focused on really an update regarding pediatric anxiety disorders. And while there's certainly a lot that we could talk about in terms of the neurobiology and epidemiology and increased understanding of risk, I've really focused this more so on treatment, and particularly around how do we decide what treatment might be best for what patient, and how do we really move beyond one size fits all with our patients. In terms of disclosures, I have the following recent disclosures. Probably the only one that is particularly relevant as we go through here is for Genamind. I did present a CME lecture about a year ago and received an honorarium for that in a grand round setting. Now, in terms of the learning objectives for this morning's presentation, we're going to again talk about the evidence for psychopharmacologic as well as psychotherapeutic interventions in pediatric anxiety disorders. And probably we'll focus a little bit more so on the psychopharm, just because, again, that's where I think there have been some pretty significant recent advances, particularly over the last 2 to 3 years. And also, I want to talk a little bit about the risk factors for specific patients in terms of how they may be at greater risk of side effects, as well as how they may be at greater likelihood of having improvement. As a reminder, most of the meds that I'll be talking about today, when I do talk about medications, are off-label, and I'll try to highlight that as we go through the presentation. Now, in terms of the outline, we're going to first talk a bit about anxiety, and particularly about the developmental trajectory of anxiety, which I think is something that can really help us in the clinic in terms of recognizing, is this anxiety that's actually representing something else, or is this a primary anxiety disorder? We'll talk a bit about the key landmark studies. Again, I'm not going to review every study of CBT, cognitive behavioral therapy, or an SSRI in pediatric anxiety. We'll try to highlight some common themes here. And then we'll, again, really get into how do we predict response. We'll also talk about psychotherapy, side effects, and SSRI discontinuation. Now, before we get started, I'd like to start with a couple of questions. So the first is, why do goldfish float when they die? The second is, why does the milk sometimes taste weird? And the third is it going to rain today? Now, these are 3 of the questions that I was asked by my twins back in the days when I used to drive them to school every morning before we moved to virtual. And I think the questions that kids ask is something that's really important to us for a number of reasons. One is that the average 6-year-old asks almost several hundred questions over the course of a day. But something really important happens as we get older, and in particular, as we train more and move into medical school. And that is that the number of questions that we ask significantly decreases over time. So That being said, I think it's really important to remind ourselves that asking why is so important in terms of understanding why treatments work, why treatments don't work, why certain patients are at risk of side effects, why certain patients have a slower improvement, why some patients get better faster. And so as we move through this presentation, I would like you to ask why, and why in terms of the different interventions that I'll be talking about. So let's first talk about when and then why kids get worried. Now, we know that the anxiety disorders are among the first disorders to really emerge in life. Now, some of this is actually accounted for by the fact that specific phobia accounts for some of what you're seeing here in this green line. But what I think is really important is that the anxiety disorders typically precede the depressive disorders. And so when I have a patient presenting, say, in adolescence with a depressive disorder, I think it's all the more important to ask about that earlier history of anxiety and whether those anxiety symptoms have persisted, because that's something that's really important in terms of tailoring treatment, as we'll talk about. The other thing I think that is important is that when we look at longitudinal studies and we look at the risk of depression, what you see here in the green line is those kids who have no prior history of an anxiety disorder. And you see, again, the likelihood of developing depression increases over time. But when we look at those kids who had a prior history of an anxiety disorder, their risk of developing depression significantly increases over the course of development. Now, in terms of how we can potentially identify maybe some of those kids that are at risk of developing anxiety disorder, we can use two specific phenotypes, if you will. One is this idea of behavioral inhibition. So in other words, these are going to be the kiddos who are going to withdraw from novel or unfamiliar situations. They're going to be more temperamentally inhibited. And again, this is a little bit different than shyness. And this is not to say that everyone with shyness or an anxious temperament needs to be treated or go to psychotherapy or anything like that. But just again, as we know from general pediatrics, there are certain anatomic issues or other characteristics that may place a patient at higher risk or lower risk for a certain disorder. And that certainly, as we know, informs our screening. Now, the other is anxiety sensitivity. And this is really the first to emerge of the cognitive risk factors for anxiety. So these are the beliefs that the anxious symptoms have very harmful physical, psychological, or other significant sequelae, and that's particularly specific for panic disorder. Now, what you see here on the right-hand side of the slide is really looking prospectively at a large cohort of children and adolescents who were followed up to about 30 years of life, 35 years of life. And what you see is that those kids who had behavioral inhibition early in life were significantly more likely to have all of the DSM-5 anxiety disorders, although separation anxiety disorder wasn't considered an anxiety disorder at the time when the study was done. So let's now move a bit into the psychopharmacologic treatment of anxiety. And as I mentioned, I'm not going to review every trial of an SSRI. In fact, I'm going to review one or two here, because I think my aim here is not to convince you that SSRIs or CBT work. It's more to help us understand and have that discussion around in whom do these interventions work best and how can we predict these trajectories. So the largest trial that we have to date of pediatric anxiety disorders is the Child and Adolescent Multimodal Study published back in 2008. And this study included about 500 kids with either separation anxiety disorder, generalized anxiety disorder, or social anxiety disorder. And we often refer to these three anxiety disorders as the pediatric anxiety triad because they often tend to co-occur. They seem to have a similar neurobiology, and they seem to have similar responses in terms of psychotherapy as well as sertraline, CBT, or CBT plus sertraline. And these patients were followed for 12 weeks. Now, what's important, and again, something I think we should take away from this presentation, is that both monotherapies, sertraline as well as CBT, tended to work better than placebo. Now, this is on average that they tended to work better than placebo. We'll talk a little bit about that heterogeneity of treatment effect, who got the most improvement, who got the least improvement. But the combination treatment far outpaced the other interventions, both monotherapy as well as placebo. Now, the only other clinical trial that I'm going to talk about is, again, not a trial to show you that escitalopram works in pediatric patients with generalized anxiety disorder, but to talk a little bit about some common themes that we see across these studies. So this is our study that was just published in the late summer of 2020. This is a National Institute of Mental Health funded study, my K23 award. And what we see here is that, like in most of these studies, in terms of, I guess I should have labeled my groups here, but as you can hopefully tell, the blue is the placebo group, the red is the escitalopram group, and these are actually standard errors, not standard deviations. So what we see is that there's certainly improvement. Improvement can happen early, although probably not at a clinically significant level. But the important piece here is that there is continued improvement over time. So your response at 2 weeks is not necessarily your response at 3 weeks or 4 weeks. There's continued improvement over time. But we should add an asterisk to that statement, and we'll talk a little bit about that. The other issue that I wanted to talk about in terms of the child and adolescent multimodal study is when we really set the goal as remission, we tend to find that CBT and SSRI and combination therapy really separate out a bit more so. So when we look at the 12-week mark, we actually do a bit better with the sertraline than with the CBT. But by 24 weeks, looking at the monotherapies, those differences have really been eclipsed. The other thing that is important is in terms of, for the CBT intervention, again, this is something that was truncated in CAMS because you were limited in terms of how long patients could be treated with placebo. But when we look farther out, we really see that probably 24 weeks of CBT is really needed in terms of consolidating some of those improvements. So just 12 weeks or 12 sessions, actually 11 sessions of CBT is probably inadequate for many of these patients. And that's something that may have underlied these differences here. Now, coming to the medication side of things, and again, I'm not going to go through all the SSRIs, but I wanted to focus on fluoxetine because I think in many ways in child and adolescent psychiatry and child and adolescent psychopharmacology, it tends to be a nice representative drug. Now, we know from studies in adults that in general, we need to block about 70 to 80% of that serotonin transporter where the rubber hits the road for these SSRIs at least at the presynaptic level. And in terms of thinking about that, again, coming back to that idea of why is this the target dose of fluoxetine or escitalopram or citalopram or sertraline? Really, the dose that corresponds with that 80% blockade is not surprisingly that dose, which we often think of in terms of our target doses for the SSRIs. So again, I really think it's helpful to understand why this is the target dose, not just that this is a target dose. And there you see the target doses for the other SSRIs and pediatric anxiety. Now, a bit of review here in terms of just some of the nuances and differences among the SSRIs. So there are significant differences in terms of the pharmacokinetics of these. And broadly speaking, we can talk about the SSRIs in terms of those with long half-lives and short half-lives, which you see there represented as cartoons. Now, with a long half-life, it's going to obviously take a bit longer to reach steady state. that means that really side effects may, and I say may, manifest late because that's not always the case. And these side effects aren't always predicted by the pharmacokinetics. Dose adjustments may require a little bit of patience here. And with the short-acting medications, again, we're faster to achieving steady state, which means perhaps that side effects may emerge a little bit earlier. We're also going to have a bit more variation in blood concentrations when a patient misses a dose, and we'll talk a bit about that later. Now, with the long half-life medication, certainly I was taught back in medical school and in training that a few missed doses may not have as detrimental of an effect, although I think, as we'll talk about later, even a few doses can actually have a pretty significant effect on blood levels, even when we are at steady state. Also, washout can take longer. Now, I'm only going to present 2 slides on the neurobiology, but again, I'm doing this because I think it really speaks to that why question. Now, when we think about anxiety, we really need to talk about the amygdala, and we need to talk about fear conditioning and extinction. And as a cartoon here, when we have emotional input, whether from the environment, something that happened at school, a expectation in terms of a exam that's coming up, we have significant increases in glutamatergic transmission really within the cortex, which then increase the activity of the amygdala and ultimately generate that fear response. Now, we have a compensatory process at play here, and we're going to leverage this in terms of our CBT and in terms of our SSRIs. And what you're seeing here with these yellow arrows is the serotonergic effect here, which is really going to dampen amygdala activity and help to at least attenuate some of that fear response. Now, CBT is also probably going to enhance inhibitory tone within the cortex, and in doing so will really retune this circuit. In other words, changing the gain of that circuit. Now, if we go down here a bit to the level of the amygdala, actually we'll do that in another slide, but let's first talk about the amygdala and that area where things are really coming together, the ventrolateral prefrontal cortex. Now, normally the ventrolateral prefrontal cortex inhibits the amygdala, and then there is also some feedback from the amygdala to the ventrolateral prefrontal cortex. And while some of my adult psychiatry colleagues would say this is the end of the story, in child and adolescent psychiatry, and you certainly as pediatricians know this well, that things change over the course of development. And so what we see is that connection, that strength of that wiring between the ventrolateral prefrontal cortex and the amygdala really changes with development. And I think this makes sense. So for example, with my 7-year-old daughter last night, we were kind of having a relatively difficult episode around something that had happened earlier in the day. And there was a pretty intense emotional reaction that, obviously this is something that was happening in the evening. It was happening after, maybe bedtime had gotten away from us. There had certainly been some brownies earlier in the day, but it was really disproportionate to what was going on in terms of something earlier that had happened at school. And I think in terms of looking at what's happening physiologically, it really makes sense. So my daughter has a very different strength of connection between her prefrontal cortex and the amygdala. So what you see here is that is actually negative until we hit about 9 years of age. And then over the course of adolescence, it becomes progressively more effective. And again, this is, I think, something that makes sense to any of us that have interacted with a child or adolescent in this age range. And what we see here is that there's an increasing ability to modulate that anxiety, to modulate those emotional responses that comes with age. Now let's, in the last neurophysiology slide, talk a little bit about that structure that we've alluded to in the last 2 slides, the amygdala. Now, the amygdala obviously is a structure that's existed since our reptilian days evolutionarily. And this is a structure that really is comprised of multiple nuclei, although we're really going to focus on two, which I realize is a bit over-reductionistic, but I think is important here. So we have the basolateral amygdala, which is an evolutionarily and developmentally newer area of the amygdala relative to the centromedial amygdala. Now, in terms of the pathways within the amygdala that generate this fear response, the lateral amygdala receives a lot of input, mostly from cortical areas, so ventromedial prefrontal cortex, sensory cortex, but also subcortical areas like the thalamus and hippocampus. And when we have input here, we can activate a lower circuit, which essentially consists of two synapses, both glutamatergic, and those give rise to a fear response. However, when we stimulate the parallel circuit, which consists of three synapses, we actually have a final synapse, that third synapse, which is actually GABAergic, inhibitory, and that decreases the fear response. Now, what's important here, is that the SSRIs seem to really work on the basolateral amygdala. Benzodiazepines seem to work here, and CBT also has its effects in terms of the basolateral amygdala. Now let's talk a little bit about the SSRIs and CBT. And I had the opportunity to work with the child and adolescent psychiatry fellows and the triple board residents yesterday. And the theme really was moving beyond this idea of one size fits all. And I'm not going to spend as much time with that today, but I really want to illustrate this with the following slide. What we see here is the response to citalopram, paroxetine, fluoxetine, and sertraline in pediatric patients, in this case with depression, but in a large federally funded trial. And what I think is pretty clear here, as opposed to what we've been talking about, is that when we look at individual responses over time, we have things like this individual here in the kind of sea green, who had pretty minimal improvement over the course of treatment relative to this person shown more in teal and in magenta, who had fairly early and very robust improvement over time. And so the problem is, I think in medicine, when we talk about our recommendations in terms of using an SSRI or using CBT or using VANC or using ceftriaxone, we really fail to understand and appreciate the individual differences that may contribute to this variation in response. Although I would argue that we're hopefully getting a bit better. Now, when we look at all of the medications that have evidence or have been studied in pediatric patients with anxiety disorders, we see that the SSRIs are associated with the largest effect. The SNRIs certainly have an effect, although it's significantly less than the SSRIs. In terms of disclosure, again, certainly not within the last 5 years, but there's one pediatric SNRI that is approved for generalized anxiety disorder, and I was the principal investigator on that study, and that was an industry-funded study. But what you'll hopefully appreciate in the next slide, as you evaluate my bias here, is that what the evidence is actually telling us is that while we have certainly positive studies for SSRIs and SNRIs, we probably should be using SSRIs rather than the on-label SNRI. And we'll talk a little bit about that here. So we were interested, given that there's efficacy data for both the serotonin norepinephrine reuptake inhibitors as well as the selective serotonin reuptake inhibitors, we were interested in knowing, does improvement over time actually differ between these treatments? And what you can see here, I think pretty clearly, is that the SNRIs are associated with a much shallower, more anemic improvement over time relative to the SSRIs, which are associated with a much more robust and a greater magnitude of overall improvement over time. And again, I think this really makes the argument here for, from an evidence-based medicine standpoint, for using an SSRI over an SNRI. Now, Another thing that probably may strike you as a little bit odd to include in this presentation is placebo response in pediatric anxiety disorders. But I think anytime we use any intervention in medicine, there is some component of placebo response. And this is where I think understanding the things that drive that placebo response can really be helpful in terms of maximizing the benefit that our patients get. So in the child and adolescent multimodal study, we looked at some of the factors that influenced the improvement that we see with placebo in these kids, remember, with generalized separation and social anxiety. And what we found was that those kids who had higher expectation of treatment success tended to have much greater and faster improvement with placebo. And so coming back to the clinic, I think that's something that's very important. And I've seen many of my colleagues, and probably myself am guilty of this, when we talk about these medications, we say, well, you know, they've been studied in anxiety. I mean, they work, you know, there are side effects. And it's kind of hard to know if the medicine's going to work or not work. I mean, we'll kind of wait and we'll kind of figure out the dose. And I mean, in the trials, it works. That's probably something that significantly decreases the expectation of treatment success. Wherein, if we actually look at the data, we know that by and large, our interventions do produce improvement in many, if not most patients, at least 60% of patients really getting to that response. And as you saw earlier, almost 60% at 24 weeks getting to remission. So again, thinking about our patients' expectations and actively managing those as we talk about our interventions. So I want to spend a couple minutes talking about pharmacogenetics. And I know that this is something that probably has been surrounded by controversy in recent years as we've really struggled in terms of applying the evidence, although there are probably some other factors that influence this in terms of some genetic exceptionalism and other things, which we can certainly talk about in the discussion. But I want to talk about two things. I want to talk about the pharmacokinetic aspects, and I want to talk about the serotonin transporter. Now, the serotonin transporter, again, that site of action for our SSRIs, how much of that we have is determined by one particular genetic polymorphism that's received a lot of attention. And I'd like to, in cartoon form, just really walk you through this so that, again, we can hopefully ask why. So folks with high expression of that serotonin transporter are going to obviously have more expression. Those individuals with decreased or the short allele of that transporter promoter polymorphism are going to have less expression of the serotonin transporter. Now, when we look at how the serotonin is recycled, those individuals who have the long allele or high expression are going to have more serotonin reuptake relative to those individuals who have the short allele. And we'll talk a little bit about this in a second. Now, synaptic serotonin is going to be decreased in those individuals with the greater expression of the serotonin transporter and will be increased in those individuals with the short allele. Now, in our NIH-sponsored study, what we actually found was that when patients were treated with escitalopram, again, probably one of the more potent of the SSRIs, those individuals who had the short form, so again, less of that serotonin transporter expression, so serotonin transporter expression. So thinking about that as less substrate for the medicine to act on, actually had slower improvement relative to those individuals with the longer form. I think that's certainly interesting, but I don't know how clinically actionable that is right now, at least in terms of our available evidence. What I think is probably helpful is if we think about the other side of pharmacogenetics, which is in terms of the pharmacokinetics. So in terms of citalopram and escitalopram, one of the main reasons why I like to study it in terms of our clinical trials is that it's more clean than many of the other SSRIs in terms of its metabolism. And also, as I mentioned, it's one of the more potent SSRIs, which makes it a little bit easier and cleaner to study from more of a pharmacodynamic standpoint. Now, it's predominantly metabolized by CYP2C19. And again, don't worry about the pathway. Really what I'm getting at is the fact that it's predominantly metabolized by 2C19. There's a little bit of 2D6 down the road, and then ultimately it's metabolized by monoamine oxidase. Now, what's important here is that when we look at the variation in terms of how folks are breaking down citalopram or escitalopram, what we see here is that those adolescents who are normal metabolizers actually have a slower improvement relative to these patients who are intermediate metabolizers and actually have higher blood levels at a given dose. So I've thrown out some terms here in terms of normal metabolizers and intermediate metabolizers and slower metabolizers and faster metabolizers. The way that I like to really think about this is in terms of this speedometer that was created by my colleague Laura Ramsey at Cincinnati Children's. And when we're thinking about activity for these enzymes, again, the expression of the enzyme is controlled by the alleles that we have for that particular gene. And obviously we have two alleles, one from mom, one from dad. Now, what's important is that these phenotypes, so in other words, whether you're poor, intermediate, normal, rapid, or ultra-rapid metabolizer, those are corresponding with our genotype. And what I really want to highlight here is that even within a phenotype, we can actually have some considerable variation. So we can have one no function allele or one or two alleles that have decreased function. Now, we can actually use this just like we use renal function to adjust dosing for other medications or use blood levels to normalize exposure and things like that across medicine. So what we see here is that when we look at adolescents treated with escitalopram and we look at what's actually happening in terms of 2C19, what we see is that if we use the one size fits all, again, following the FDA guidance in terms of dosing, so starting at 10 milligrams and then at 4 weeks having an optional increase to 20 milligrams, we see that there's considerable variation here in terms of those patients who are poor metabolizers, intermediate metabolizers, normal metabolizers, or et cetera, rapid or ultra-rapid metabolizers. Now, I mentioned earlier in the presentation that it's probably more than just pharmacokinetics. And what I really want to illustrate here is the story of 3 patients. And what we see here is a patient, an adolescent, a 16-year-old girl with intermittent adherence to her escitalopram, starting at 5 milligrams, then going to 10 milligrams, then going to 15 milligrams. And despite what you might predict based on things like I learned in terms of medical school pharmacology about steady state, really just missing 3 doses here and having some variable adherence in terms of timing can actually have a pretty significant effect on blood levels. Now, we also see that being the case in an individual here, in fact, a 17-year-old girl who just missed 2 doses, but consecutively. And then here you see a much more variable dosing in this patient who you see also just had increasingly difficulty with adherence. Now let's talk about the non-antidepressants, and I think it was really nice that Dr. Giles' case involved guanfacine ER in a pediatric patient earlier with depression and anxiety, although maybe ADHD as well. Now, we published a study looking at guanfacine ER in pediatric anxiety, and certainly this is something that's been used off-label. I think it is important to think about the implementation of many of these studies as we're talking about them, because, again, not all of these studies are really exchangeable in terms of how they were implemented. And this is a study that probably we really stacked the deck against guanfacine, although we did still see some evidence of efficacy here. But what's important is that we randomized patients 3-to-1 to guanfacine versus placebo, which, if we think back to what we talked about with expectation, really accentuates that placebo response. And again, that's something that we saw here. We also did other things in terms of really underdosing guanfacine in this population. And again, if we use the ADHD literature as a guideline, for ADHD with guanfacine, there definitely tends to be a dose-related effect in terms of efficacy, with us really needing to be at that 0.08 milligrams per kilogram in order to get the maximum efficacy. Again, we were well under that here in terms of our average dose. Now, I want to spend a couple of minutes, and I think I'm doing okay on time, with regard to CBT or CBT. Now, when we think about cognitive behavioral therapy, we have two components of that. We have the cognitive component, the C, and then we have the behavioral component. And this often involves exposures. So having the patient do something, and these can be things that are pretty simple. We were talking about with the residents yesterday, having the patient check in with the receptionist if it's an older adolescent, or if you have time walking around the hospital and prior to COVID, and asking about directions or how to find something, and then talking about that. All of these really representing exposures. And what we find is that the exposure component is probably the most important ingredient for effective CBT, although there are probably some age effects there as well. And you see this in this nice study by my friend and colleague Tara Paris from UCLA, where she looked at the trajectory of improvement with the cognitive portion versus the exposure portion. And what she really saw is that there was an acceleration of response when that exposure component was introduced. All right. Now, we recently are in the process of doing a large scale meta-analysis where we're looking at all of the pediatric trials of SSRIs and CBT, and we're really trying to understand where that amplified response comes into play. And what we're finding is that that additional benefit of CBT really comes in probably around 10 weeks. So it's something that, again, this is probably speaking to how long of a trial we need for CBT. Again, not just 1 or 2 sessions, not even 4 or 5 sessions. We're really needing to be out here closer to 10 sessions to start seeing that additive benefit of the CBT. Now, in the interest of time, I'm actually going to move through this slide pretty quickly. But what I wanted to illustrate here is that there are different factors that predict response in kids who receive CBT plus an SSRI versus kids who just receive an SSRI. And what I think is helpful here, at least from a clinical standpoint, is that severity is probably the only thing that drives this difference in SSRI response. And that's probably something that speaks to those patients with more severe anxiety really needing both CBT plus an SSRI to have the most gain in terms of treatment. But I think from more of a policy standpoint and in terms of how we develop our therapies, we have tremendous effects across whether you have ADHD, whether you're older or younger, whether you have major depressive disorder or not, and also in terms of being a member of a minority group, that really impact the trajectory of CBT plus SSRI response. And again, I think this is an issue with, just like we've talked about with our medications, we use a one-size-fits-all approach in many of these studies with CBT, wherein we probably should be doing things differently in, for example, patients with MDD, or should make more adjustments in terms of age. Now we're going to finish up talking about the antidepressant side effects, and I want to really focus in on a couple of these. We recently published a meta-analysis in our Academy journal in the fall of last year, and this is a study that looked at, across all of the anxiety and OCD studies, the side effects of the SSRIs compared to the SNRIs. And really the take-home message here is the SNRIs are better tolerated, but that's tempered by the fact that they're less effective, as we saw earlier in the presentation. Now, one side effect was different. Actually, several side effects were different, but one in particular was different between the SSRIs and the SNRIs, and that was activation. Now, activation has been one of those side effects that's really been elusive in child and adolescent psychopharmacology because it's so difficult to define. Activation is really a constellation of symptoms. It includes disinhibition, mild, not mania. It can include a little bit of more difficulty with sleep, more restlessness, hyperactivity. It can also include some transient irritability. Now, what's interesting is that this really does tend to be more of a pharmacokinetically driven process. And what do I mean when I say that? So in terms of looking at some of the studies that we have, we know that for fluvoxamine, fluoxetine, and escitalopram, the SSRI exposure, in other words, blood level or blood concentration, seems to really be related to whether we develop activation. We've also shown with escitalopram that in kids with anxiety as well as in kids with depression and anxiety, it's related to 2C19 metabolizer status, which also is related to blood level, as you see here in terms of area under the curve. Now, in terms of managing activation, just my general tips, first of all, make sure it's not something else. And that includes both general medical conditions as well as other family factors, substance use, adherence problems. Also, from a practical standpoint, I think my first intervention tends to be reduce the dose, which generally tends to be very helpful, although we can switch from one medication to another. And then also there's some clinical suggestion that those patients who have ongoing psychotherapy may have a slightly lower risk, at least based on the CAMS data, of having activation. Now, I alluded to how severity can help us choose a particular treatment. And this is a reanalysis, again, of the child and adolescent multimodal study, which, as you recall, compared sertraline to sertraline plus CBT to CBT monotherapy to placebo. And what you see here on the left-hand portion of this graph is that those patients with severe anxiety really needed the combination treatment in order to get the most benefit. I wanted to include just a couple of slides on refractory anxiety, and we'll hopefully finish up here in the next 3 minutes and allow some time for discussion. But in terms of my general approach, certainly reevaluating medical conditions that could be contributing, but also probably even more importantly, thinking about, perhaps as I've improved the anxiety, other things that may be perpetuating symptoms. So family factors, ADHD. Has there been an untreated ADHD that's contributing? Are there family factors, occult substance use, adherence, and so forth? Now, in terms of from a pharmacotherapy perspective, I tend to be somebody that goes back to the SSRIs. So if I have a treatment failure to one SSRI, I still do tend to go to another SSRI. Also, I think really addressing those associated symptoms in terms of ADHD, in terms of sleep, et cetera. Again, this is something that's very, very important. And then I think really of utmost importance is really trying to ensure that we've maximized our individual psychotherapy. Now, the comorbidity aspect that I alluded to in that last slide, again, from my background standpoint, I do pharmacology research, and I'm not trying to look at everything through a pharmacology lens, but I hope that this gives us some pause as we again think about why. So when we look at the child and adolescent multimodal study, and we look at those kids who received CBT, what we find is that the kids who had ADHD did far worse than their non-ADHD colleagues when they received CBT. Or rather, they didn't have as much of an improvement. And this is where, when we think about what we're doing with our ADHD medications, it really starts to make sense. So in this trial, kids could be treated with their ADHD. But again, we're thinking about medicines like methylphenidate oros, Concerta, one of the proprietary names, or Adderall XR, or mixed amphetamine salt, extended release. And what we see here is that with many of these medications, we're looking at a duration of action of 6, 8, or 10 hours, depending on whether we're taking it with or without food, depending on whether we're taking it actually at school or prior to breakfast or just before the kids get on the bus. And so the problem is that we were often giving the CBT or administering the CBT after school. So unfortunately, at a time when our ADHD is now effectively untreated because we've already cleared our stimulant medication. So in many ways, I think in the CAM study, we set some of these kids up with CBT to not do as well because we not adequately managed the ADHD. So again, this probably isn't an issue of the ADHD. It's probably more related to the management thereof. Also, social anxiety was something that really tended to differentiate those kids that responded and didn't respond to some of the interventions, at least those interventions that had a psychotherapeutic component in the child and adolescent multimodal study. I want to just end with one slide related to how do we stop these medications, particularly the SSRIs, in kids with anxiety and depression. And this is, to my knowledge, the only study that we have of discontinuing an SSRI in kids. And this is a study that used fluoxetine, which again, you remember from earlier in the presentation, has a relatively long half-life. But what was important was that when kids stopped the fluoxetine, again in a double-blind manner, what we saw was most of that relapse actually happened within the first 3 months of treatment. And so, again, I think this is something that's really important in terms of how we monitor kids as we're stopping the medications, and also probably how slowly we discontinue these medications. So in conclusion, again, what we talked about is that the SSRIs and the SNRIs are effective in terms of pediatric anxiety. The SSRIs probably produce some faster improvement and some greater improvement. We've reviewed the evidence for psychotherapy in pediatric anxiety and really talked about the importance of exposure and also the importance of managing comorbidity there. Now, in terms of antidepressant side effects, we've talked about activation. And we've talked about the differences among the SSRIs and SNRIs with regard to that risk. And then we've talked a bit about comorbidity. So I certainly don't do this work alone. I have a wonderful team of collaborators and students and postdocs and imaging folks and pharmacologists and others that I work with really across the globe these days. And certainly the data that I presented would not have been possible, or the analyses thereof, without them. So at this point, hopefully we can take some questions. This is one of our pictures that we took with a partial group at a meeting that we had to have in person. You can see this is a couple months ago, and I, as my chair asked, despite the deceptive perspective here, there is actually 6 feet between us. So I think now we have some time for questions.
Well, thank you so much. This really was a next level talk. You know, I'm so happy to learn about the reasoning on the different doses and receptors and patient selection and the even if I can't in my daily practice, figure out if somebody tests them to see if they're an ultra rapid or a slow metabolizer, just knowing that there are the different types that kind of explain where, maybe this person is someone who I shouldn't push a dose on, or I should. So it kind of, it helps me understand that. The longer length of the CBT, the neurobiology. I didn't know the amygdala had different parts inside it, but that was pretty cool. I just thought the amygdala was like one thing, but apparently not. But this is really, really interesting. Let's go to these questions. Chuck Norland asks, he says, excellent and useful information. Thank you. In your environment, how do you identify and vet and refer to and maybe even train the CBT therapist to expand the optimal therapy and focusing on the B part?
So great question. And can be done pretty simply. So one of the things that I ask is, so tell me about therapy. What happens? Who talks? What kind of stuff do you guys do? Do you do stuff out of therapy? So those questions can oftentimes be very, very helpful just in terms of assessing what's going on in terms of the therapy.
Yeah, it sounds like the patients even have helped you vet the therapist. You say,
right.
Did your therapist give you homework, and what did you do? Did they
those types of things? Yeah.
Situations. Okay. And Yuji Wakimoto says, thank you so much for your talk. Regarding SSRI side effects and activation, in what circumstance would you hold and wait at the current dose to see if the side effect would subside rather than dose adjust?
So I tend to be someone who does tend to dose adjust, even if it is more for psychological reasons rather than pharmacologic reasons. Again, that doesn't mean that we don't return to the prior dose the next week. But I think it is still important to acknowledge and respond to particularly a side effect if it's causing some distress for the patient. Again, that might be a nominal decrease in terms of dose, but I'd say probably 90% of the time I do tend to decrease the dose, albeit temporarily.
And it sounds like there may be sort of a reverse expectation effect, where say, I expect that when I reduce this dose a tiny bit, that side effect will subside.
Right. Right. Absolutely. I think implicitly that's certainly something that's there. Definitely.
Well, we have some questions from our child psychiatry team.
Okay.
So, yes. So one of our colleagues, Chris Rich, asked about augmentation strategies. So, if your SSRI is partially working, you've kind of optimized it, evidence for augmenting with Buspar, guanfacine, or anything else?
Yeah, so great question. So in terms of, I think from the SSRI standpoint, making sure that I'm really dosing. So if I've had a partial response, even at a relatively high dose and I'm not running into side effects, I will push the dose. Again, just recognizing that there's pretty considerable variation there. Of course, my favorite augmenting agent is therapy. And so really making sure that we're maximizing what's going on there. From a pharmacologic standpoint, and again, probably less so in the primary care setting, more so in the specialty, subspecialty setting, I do tend to use the alpha-2 agonists. Things like guanfacine. I do sometimes, depending on the extent to which it's episodic, use an H1 antagonist like a hydroxyzine. Also, I will tend to pretty aggressively manage sleep in terms of using some sleep medications, to kind of particularly address initial insomnia. Also, with regard to any comorbidity, I want to make sure that I'm either not doing something that's worsening the anxiety. So yesterday we talked about there's certainly some evidence with the ADHD treatments that the mixed amphetamine salts or the amphetamine-based treatments may worsen anxiety, whereas the methylphenidate-based treatments don't tend to actually worsen that. So those tend to be my main things. I tend to not be somebody that uses much of the mixed dopamine serotonin receptor antagonists, what we used to call the second generation antipsychotics. Although there certainly are some rare circumstances where, particularly if I have a significant depression component, I have augmented there. But by and large, it's more the former things that I mentioned.
Okay. Okay. Thank you. And then you had mentioned, I mean, you had talked about, which was, I think, again, fantastic, understanding the why of our dosing and kind of, how we get at that 20 to 40 milligrams of fluoxetine, why that seems to be an effective dose, so forth. What do we know about kind of going up higher than that and kind of pushing that dose? And specifically, the question is around kind of, pushing the dose a little above our FDA recommendations. So going above 20 milligrams of escitalopram or that.
Yeah, so certainly off-label in terms of those higher doses, but again, I think this is where the idea of dose really becomes problematic. On the psychiatry side, we don't necessarily talk about a lithium dose. We think lithium levels, and the same with divalproex, or the same. Really, probably we should be thinking that way with ceftriaxone as well. But in terms of if I have a patient who's an ultra rapid metabolizer, of 2C19, even though I'm giving 20 milligrams, I'm not getting a blood level that I would expect with 20 milligrams in a normal metabolizer. I'm only getting the equivalent of about 10 milligrams. So again, it makes sense, to push to that 30 milligrams to essentially get the normal expected blood levels that I would see in a normal metabolizer at 20 milligrams.
Yeah. So I mean, you hinted at this and have talked about this, but so what is the current clinical utility of pharmacogenetic or pharmacokinetic testing? I think that's something I'm asked by pediatricians, constantly every day.
Yeah. So I think from a pharmacogenetic standpoint, I don't think that we have the evidence to use things like the serotonin transporter to say you should use an SSRI or you should use an SNRI. I do think that we have evidence in terms of adjusting dose based on that. I think the other problem where we really see issues is when people perhaps look at a lab report and they think about that lab report just in isolation. So the lab report obviously is, as you know, Dr. Giles, is not telling you to use this medicine or not to use this medicine. You have to come into this with saying, I'm going to use nitrofurantoin for my UTI, and then you look to see whether the patient has an appropriate creatinine clearance and whether the organism is susceptible to that. And I think while we do this with other areas of medicine, we forget about this sometimes when we look at these pharmacogenetic testing reports. And so, someone will go in and use a medicine which we really have no evidence for using in a pediatric population or evidence against efficacy. And they'll use that, based on a misinterpretation of the report. And I think this is really something that, has hurt our field considerably.
Yeah, absolutely.
Okay, well, we're at the official adjourning for the morning, but if you have a minute, Dr. Strawn, we could pretend that people are coming up to the podium to ask you questions.
That's fine.
Is that okay? All right.
That's fine.
So one of them from, and then Dr. Giles might have more, from Richard Aguilar says, well, as an aside, he does stress breakfast therapy just to many of his patients skip breakfast. He wants them to eat breakfast.
Absolutely.
He asks about if there's more depression than anxiety, or if someone is more anxious than depressed, does that lead you to choose one SSRI, over another? For example, like fluoxetine if they're more depressed, sertraline if they're more anxious, or how do you do that?
So I think really in terms of, and this is where our reanalysis of the Tordia study is probably helpful, I do tend to still stick with the SSRIs. And from my standpoint, I tend to use fluoxetine and escitalopram as more of my first line interventions, and that's not necessarily based on the cumulative amount of evidence. It's more based on ease of dosing, quite frankly. With sertraline, it's going to take me a lot longer and a lot more titration to get to where I need to be. Whereas with fluoxetine, I can be there more quickly, and the same with escitalopram. So it's really more of a pragmatic issue for me.
I see. Thank you.
I'm curious a little more about the placebo effect, right? And how do we really use that clinically, right? Like, how is the best way for us to be introducing, you know, whether it's medications, whether it's therapy, whatever our intervention is, in such a way that is setting up those positive expectations, but obviously is still, realistic and truthful.
Right.
We're obviously discussing risk benefits.
Right. So I think I'm, although dispositionally I'm not normally a glass half empty kind of guy, I think I may sound that way for the next 20 seconds or so. But I think really for me, it falls to the issue of aggressively managing negative expectations. And so one of the places where I'll really stop the train is when the parent says, well, what are we going to do if this doesn't work? And I'll really try to back that up. That might be a situation where we delay the medication until we can really aggressively handle that. So from my standpoint, I think a lot of it is really managing the negative expectations. And oftentimes that's tapping into some other things within the family that really need to be handled actively.
Yeah, no, that's a great point.
Because we also know that it's not just the child's expectations, it's also the parents' expectations. Both significantly and independently drove placebo response in that study.
Mm-hmm. Yeah, that makes a lot of sense.
We just have a couple last ones. When you're stopping or tapering therapy, when somebody's better, they kind of been on it for a long time, do you taper the medicine first or the therapy first? And I think both need to be tapered. You wouldn't suddenly cut someone off from a therapist either. But and then the timing of it, like school or summertime, or do they need to show they're good under stress, and be in school while you're tapering, or how do you do that?
So a couple things there. So I tend to really like to go to the 9-month mark of being symptom free. And the discussion that I normally have is, this is not a rigid rule. So if 9 months is the week before the SAT, that's not the week that we're going to start the taper. If it's the week before college, again, not the week we're going to start the taper. I do tend to titrate off the therapy first. And again, most of the time I'm able to go back to that if needed. And so, one of the other issues is that with the tapering, I tend to do it very, very slowly. And I like for it not to be in a time of high stress, but I also like for it not to be in a time of no stress. And again, I think that's something that's really important because I need to know how much was the medicine really doing, and it's so tough to assess that if I'm in the middle of, summer and things are great because I'm at the beach and.
That makes sense. And the very last question, thanks so much for sticking around. This is great.
My pleasure.
Have you found that the teletherapy, with telehealth CBT, does that work as well, or maybe even better because it's more accessible and like easier to get to the appointment?
So we're just starting to work on that. And actually, this has been something we've spent a lot of time with this week in particular. So we know that adherence is probably a little bit better. In terms of no-show rates and things like that. We think that many of the aspects are probably comparable in terms of, the clinical trial data that we have. We're seeing similar effect sizes or maybe a little bit better. From more of my personal kind of experience, particularly with the younger kids, is that it's just so hard for me to do an exposure and to really talk through those types of things. I'm somebody that likes to go down to the cafeteria, that likes to, go ask people for, directions and, ask things that I know the answer is going to be no to, so we can kind of talk about that. And that tends to be what's worked for me. And it's just so hard for me to do those in vivo things, in a telehealth environment. That being said, as we were talking about earlier, I think we will continue to get a little bit better with this. So.
Yeah, that's amazing. Well, thank you so much for teaching us this morning, and for
thank you for having me
as well. And we really hope to have you here in person sometime, because we'd like to reconnect with you again. But thanks very much.
Thank you so much. It's been a pleasure. Good to see you guys.
Take care.
Thank you.